Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Cancer Conference Update. As today, we're going to talk about the 2025 ESMO Annual Meeting in Berlin that concluded recently, and we'll be focusing on the breast cancer papers from that really fascinating meeting. Today, we're going to actually go for 90 minutes, not 60 minutes, because there's so much to cover. I was telling the faculty I feel like I used to feel in college when I was cramming for a big exam, trying to remember all these things, but thankfully the faculty's here to keep me on track. And we do have a great faculty today, Professor Giuseppe Curigliano from the University of Milano, European Institute of Oncology in Milano, Italy, and Dr. Priyanka Sharma from the Drug Discovery, Delivery, and Experimental Therapeutics Program at the University of Kansas Cancer Center in Westwood, Kansas. So we are going to talk about the ESMO meeting. I've got a lot of press, a lot of very interesting, practice-changing presentations. As always, and particularly today, we're going to be talking about a lot of the use of non-approved agents and regimens. So check out the package information for specific indications. So we're going to start out with what I think a lot of people think may be the biggest highlight of ESMO period, not alone breast cancer in terms of HER2 positive breast cancer. Then we'll talk about ER positive and then triple negative breast cancer. And as we go along, we have some cases from our faculty to try to put this in more clinical context. I'll say too that I met with Priyanka about a week ago. We recorded a session for our micro-learning module that we're going to start sending out after this. So I already had a chance to talk to her a little bit about how she thinks about it. We'll hear more and also hear from Giuseppe. And Giuseppe, I'm very interested. You know, we saw, of course, at ASCO, the Destiny Breast 09, now looking at pertuzumab in combination, TDXD in combination with pertuzumab, very positive results. Here, we saw more data from the trial, looking at subgroups of interest in this study. And, you know, every subgroup that they looked at, whether it was de novo or recurrent, hormone receptor positive or negative. And there's another thing I wasn't really aware of, PIK3 positive. There in the past, we've seen maybe not as great of an advantage, but in terms of this trial, we did see the advantage. So in a second, Giuseppe is actually going to present a case of a patient who was on this study, but I just want to ask you in general what your thoughts were about it, what you thought about the data that was presented at ESMO, and the big clinical question, Giuseppe, which is how is this going to play out in practice? Are we really going to give indefinite TDXD or are we going to stop and go to maintenance? Any general thoughts about what you think would be an ideal approach based on this data?
You know, with more than 40 months of median progression-free survival and for sure an overall survival benefit, I am still waiting, of course, for the third arm that is TDX as a monotherapy. These data are for sure practice changing. In my experience, I know perfectly that giving for 3 years TDX, I don't believe it's feasible in all patients. In some patients it is, but not for all patients. What we need to do maybe is to design a pragmatic trial in which we calculate the median time to achieve the best response on the TDX pertuzumab arm, you stop and you maintain. So I am not telling we need a prospective randomized trial, but for sure a single arm pragmatic trial, because maintenance is for sure the main question in the context of this trial.
So Priyanka, in a second, we're going to see a really interesting case. Again, a patient was on the study and kind of interesting follow-up in terms of what happened. Before we get into that, what are you thinking about, again, theoretically, if you have access to this regimen? Are you going to use it selectively? Which patients are you going to use it in? And again, what are you going to do in terms of maintenance? Are you using CDK, Palbo in ER positive, triple positive patients? Any global thoughts, Priyanka?
So I think, as Giuseppe said, I think this is practice changing for most patients. If you don't have good performance status or lung issues or other things, then we might not consider it. But it gives such robust responses early. I do struggle with trying to keep people on beyond a year mark, even the fittest and the healthiest ones. So some maintenance strategy would be really beneficial in practice. And don't want to forget the patina data for the patients with hormone-positive disease with the CDK inhibitor. We do need more trials, and they may be single-arm studies to inform the practice for those patients. Outside of those trials and that data being available, I am offering patients going on to HP plus endocrine therapy, HP plus pelvo, and endocrine therapy to maintain quality of life.
So, Giuseppe does these incredible write-ups, so I really recommend you all check out the slides that we have in the chat room, and we'll be distributing them afterwards. So we're not going to go through every detail. They're very self-explanatory. I just want to get to the key points here. So you have this young patient, 24 years old, premenopausal, some family history of breast cancer. And I want to just kind of move to the point at which she gets a metastatic disease. And then this is in 2024, just about, I guess, really a year ago, gets started on TDXD and pertuzumab on the study. She was obviously HER2 positive, but also ER positive. Can you talk a little bit about what happened in terms of the images once you started treatment, Giuseppe?
So this was a patient with a de novo metastatic disease. This is really important. So you can see here in the imaging the 23 millimeter breast cancer and an important axillary lymph node. And this is the baseline imaging in April 2024. And when we performed the first CT scan, there was an impressive response, almost complete disappearance of the primary tumor, disappearance also of the axillary node. And if you check here, because there was a metastatic disease in the liver, there was almost a complete response also on the liver. So the first observation I would like to do when you give this combination is very active. And you can achieve also an important response in a very short time of exposure to the treatment. So this is how imaging can support this.
So what I'm really interested to hear about is what Priyanka would do in terms of this patient, in terms of the follow-up, because it turns out that this past summer in July, the patient was noted to have an asymptomatic brain met and a new liver lesion. Again, anything you want to say about the images? And then we're going to ask Priyanka what she would do in this situation. She was clinically stable at that point, it sounds like.
So the question, of course, whether is to treat or not this brain met, because, this is formally a progression. But the brain mets are asymptomatic, but there is the appearance of a new liver lesion. So the main question outside the clinical trial, because in the clinical trial, this is formally a progressive disease. What we are going to do now, can we treat with the local regional treatment, the brain met, and eventually the liver lesion, and proceed with the same therapy outside the clinical trial, in this case, TDX alone? Or should we go to a second-line treatment with tucatinib, trastuzumab, and capecitabine, or eventually with pertuzumab, trastuzumab, and taxanes? So this would be the main question for the future because we don't have data following Destiny-9 regimen.
So, Priyanka, if there wasn't a new liver met, a lot of times you think, okay, CNS progression, treat the CNS locally, keep going, but now you've got a new liver met. Any thoughts about what you would have done in this situation, Priyanka?
I would be inclined to switch therapy to a tucatinib-based regimen. The new brain met appeared while on TDXD, so the chances this patient would have more brain disease over the next 6 months is substantial. But I don't know that there's a wrong answer here. I think you could potentially also continue on TDXD and loco-regionally treat the two areas and sit tight and monitor and change at the next progression.
And this is what
art of oncology. What did you do, Giuseppe?
What I did is, I did nothing on the brain met because it was asymptomatic. So observation was my selection. But what I did is a thermal ablation on the single liver met and continuing with TDX. And actually the patient is still on TDX. So finally, the idea of switching, since you have a very active regimen, so I decided to try, this was an oligoprogressive disease, to maintain the treatment and to treat with a local regional approach, the liver lesion.
And the brain disease has stayed stable, I'm assuming?
It's still stable, yes.
That's nice.
Still stable, yes.
Yeah.
All right, let's get into maybe the biggest story that in terms of breast cancer, at least in terms of new data, was in the neoadjuvant setting, both neoadjuvant as well as post-neoadjuvant. We saw the Destiny Breast 11 study looking at neoadjuvant TDXD alone or followed by paclitaxel trastuzumab TDXD for high-risk hormone HER2-positive disease. And again, Priyanka goes through this in the micro-learning module that we're going to send out. But you do see an improvement in terms of path-CR in the TDXD arm, an improvement in terms of progression-free survival with a hazard rate of 0.56. I don't think there was any big surprises in terms of what was seen in terms of tolerability. So we have to take that data in terms of demonstrating the benefit of TDXD and THP, the sort of split treatment, versus what we saw in the Destiny Breast 05 study. Now looking at TDXD in the post-neoadjuvant, sort of the Catherine trial type setting, but now much higher risk patients who went into this with residual disease. And again, not a big surprise. I think almost if you were going to predict what you would see, you probably would predict this, even down to the hazard rate, with a very impressive hazard rate of 0.47. And, in terms of PFS, again, I think the tolerability issues here was predictable in terms of acute issues with GI toxicity, et cetera. So again, in a second, we'll ask Giuseppe for his case. But first, I want to start out and ask you, Giuseppe, in general, you have both these trials coming in at the same time. Or are you going to go, in what situations right now do you think you'd want to start with TDXD neoadjuvantly? In what situations would you wait? And then would you use it only in the high risk as opposed to neoadjuvant residual disease? And then I guess another question would be, if you use TDXD as neoadjuvant, what do you do if they have residual disease after TDXD, which we're going to see in your case? But first, Giuseppe, can you kind of give us your global take on this data?
I believe these data are practice changing. When we designed the Destiny 11, that was not powered for event-free survival. The primary endpoint was PCR. The idea was to target the high-risk population. Don't forget that in the Neosphere trial, the rate of PCR in the high-risk population is very low, is less than 50%. So the idea of sequencing TDXD followed by paclitaxel, pertuzumab, and trastuzumab was behind the concept that maybe if you incorporate an ADC, you can increase the rate of PCR. And this is what we observed. 63% in HR positive, 67% in the overall population, 82% in the HR negative. These data, in my opinion, are practice changing. Of course, the main question is what we have to do if you have a residual disease. We don't have absolutely data. In the protocol, in the arm with TDX alone, in case of residual disease, recommendation was a sequence of anthracycline and taxane plus dual blockade. But actually, if you have a residual disease after the experimental arm TDX PTH, are you going to give more TDX? Are you going to give eventually TDM1? This is an open question. Also here, we need pragmatic real-world trials. So the uptake is consider this regimen in the high-risk population because you have a higher probability to get a pathological complete response.
I really love the idea of thinking, this is practice changing, but we're not exactly sure how it changes the practice because it's kind of complicated. And I guess one of the questions is, first of all, and I'll ask you, Priyanka, again, assuming you had access to even, let's say you have access in any neoadjuvant situation, would you still hold off on using TDXD unless they're very high risk, or would you offer it to everybody?
I would follow the trial, the really high-risk patients, because those are the ones that we don't get optimal PCR rates with our current regimen. And that balances the toxicity. And it's just 4 doses, right? So that minimizes the lung disease and other toxicities for these patients. If we had access to it, I would follow the inclusion criteria for this study. Unless, there's situations where somebody has bad neuropathy, right? You cannot give them a taxane or a platinum, right? And you're kind of stuck. So in that situation, this opens the door for us to be able to give an ADC that doesn't cause neuropathy for a longer period of time in neoadjuvant setting to get them to the best PCR probability.
So whenever we get into the real world, it always gets a lot more complicated. And this is a fascinating case, another great case from Giuseppe, a 61-year-old woman, a little bit of a family history, prostate, pancreatic, ovarian cancer. She presents with a triple positive breast cancer, 21 by 14 millimeters. You can see here on the imaging, found to have ER positive, HER2 positive, T2CN1M0. She actually went on the Destiny 11 trial, and she's also BRCA positive, correct? Am I correct in that?
Correct. That's correct.
So it's about to get very... So here we go, an incredible case. So she gets Destiny 11, and I guess responds to that. But the problem is she has
response, but the pathology, there was a massive residual disease. Look, because the stage after surgery was an YPT2, YPN2A. So here we have a residual cancer burden 3, and there is a patient with the germinal BRCA mutation and with the residual disease after TDX, pertuzumab, and chemotherapy. So to Sharma, now the question, what we are going to do in this patient.
So I think it would have been complicated enough if she just had a residual disease, but now you've got BRCA and PARP inhibitors to consider. So again, I'd love to put this case out to 20 investigators. We might get 20 answers, but Priyanka, any thoughts about what you would do? And then we'll hear what actually happened.
So I would be less enthusiastic about continuing TDXD. I mean, this is still a massive amount of residual disease. For these tumors, perhaps they're more endocrine dependent than we think, given the BRCA2 underlying mutation. So I would try to optimize the endocrine part of things and would be real tempted to consider olaparib, although the Olympia trials did not include patients with HER2 positive disease. But I would be tempted to kind of somehow sequence the olaparib in this situation. Maybe come back with, maybe do TDM and lack of data, but TDM1 and then olaparib after that, along with endocrine therapy.
I think there's a...
No, this was a patient that finally our indication was to give TDM1 and then olaparib, but she was not from Milano. She went in another center. A colleague, what they decided is to give anthracycline, you saw, followed by dual blockade, and then olaparib. So personally, my indication was TDM1 followed by olaparib in this patient. Yes.
So I guess we're also waiting. There's a press release out there of a post-neoadjuvant residual disease. You have a TDM1 plus tucatinib. So maybe 6 months from now, you'll be treating a patient like this with TDM1 and tucatinib, but we'll have to see what those data show. So we're going to move on now and talk about hormone receptor positive breast cancer. We saw some interesting follow-up now on the adjuvant CDK trials. First, the Monarch E study looking at abema. We have significantly more follow-up than the other trial that we saw follow-up on. And now, finally, we're seeing survival benefit, Priyanka, that you discussed in our session together, looking at adjuvant abema in the longer-term benefit. It's not a gigantic, bump, but it's there. It's statistically significant. And also the disease-free survival analysis shows you still are seeing this benefit. We also saw a follow-up on the Natalie study, a little bit different entry criteria. They had no negative patients in that. And at this point, they're not seeing a survival benefit. But again, maybe the follow-up's a little bit early for that. So I'm just going to come back to you, Giuseppe, and say, and we'll get into a case in a second, how have you been deciding when to use adjuvant CDK? What criteria do you use, and how do you select between abema and ribo? And does seeing these benefits, the survival benefit now with abema, change how you look at it? A lot of people started looking at first-line metastatic disease when they saw a survival benefit with ribo. Do you feel the same way here, that now you've got survival benefit with abema, Giuseppe?
But usually what I do in clinical practice for the very high risk population, according to the monarchy criteria, usually I prefer to give abema because you have a clear benefit in overall survival and the sustained invasive disease-free survival benefit after 7 years of follow-up. So according to the inclusion criteria of monarchy, large tumor, of course, 4 or more nodes, or also 1 to 3 and more than 5 centimeter, my option is exactly abema. For patients with non-negative disease or limited node involvement, in which you have biological features like high-risk oncotype DX, I prefer to give a ribo because with the lower dose, even if 3 years, is very well tolerated. So in a patient like this, I completely agree on the selection of abema. This was the selection I was going to do also in a patient like this.
So, Priyanka, you have this 62-year-old woman, ER-positive, HER2-negative disease, high oncotype, positive sentinel node. And she had got adjuvant abema, but what I would like you to talk about is she was on a trial looking at dose escalation of abema, which we've seen now. It seems to be very effective in terms of ameliorating the issue of diarrhea. Can you talk about how she did as you put her on this study and what happened when you escalated the dose and how she did in terms of tolerability?
So I think the tolerability has substantially improved since we've started putting people on this. This is more of a quality protocol here at our institution. And we just build their GI tolerance so that they are not stopping the abema for diarrhea. The other issue with these patients, they've just come through chemotherapy. They've been through a lot, right? So they're running into this treatment fatigue, and any bit more toxicity is less tolerable to them now. So I've been really encouraged by this. I know that there's another version of dose escalation that came out of the trade protocol. We've kept it simple, just 100 BID for 2 months and then escalate if they're doing fine, so that they don't have to come every 2 weeks for an assessment. She did have issues with arthralgias from AI, which we still tend to struggle with in our patients. And since she's on abema, I could switch her to tamoxifen, that you can give the 2 drugs together, rather than stopping everything altogether.
So speaking of arthralgias, actually we're going to get into that with this case that comes up here because we want to talk about the SERENA-6 trial, where at ESMO we saw more data. Of course, this was initially presented at the ASCO meeting, the plenary presentation, looking at the use of the currently unapproved SERD camizestrant in patients who are followed for development of ESR1 mutations without clinical progression, demonstrating a benefit, which we again saw at ASCO in terms of PFS, at this point not in terms of survival. And I think at ASCO we even saw some hints that patients did better in terms of tolerability. We saw more data at the ESMO meeting, again, reinforcing quality of life issues. And so in terms of pain, fatigue, shortness of breath, in a way you can understand that developing progressive metastatic disease could have an altered, poor effect on quality of life, both physically and emotionally. But also you have the issue of people coming off an AI, and maybe they have AI-related toxicity that they're not going to get on Serena. So this study was very heavily debated. I came away after hearing the discussion at ASCO thinking all the investigators were going to be saying, hey, this is not ready for prime time. We want more data. But as our group always does, we started to survey people about it. I'm going to show you a number of findings very briefly. We have 4 posters we're presenting this year at the San Antonio meeting related to these 2 surveys. We did one of community-based general medical oncologists. People are taking care of all types of cancers. And then this is actually before imlunestrant was approved. It was this summer. And then we also surveyed 20 investigators, including our 2 faculty members. I found the results very interesting and not exactly what I was expecting after hearing the discussion. I thought everybody was going to be, let's wait. So first of all, the general medical oncologists were very pro doing this. 2/3 of them were ready to do it, use the SERENA-6 strategy. And even though most of the investigators said, no, this is not ready for prime time, 7 out of the 20 said, yeah, it is. And I can tell you the names of those people. They're pretty prominent people. So I call this kind of a split decision about how people view this. And I don't know, Giuseppe, you actually have this patient here was in the SERENA-6 study. Before you present that, though, just kind of curious what your global thought was about this, Giuseppe. You know, this issue comes up all the time in oncology, every single cancer. It's a little different because it's, molecular progression, but it's still PFS without survival benefit. Very controversial situation. Before we get into your case, Giuseppe, what was your take on SERENA-6? Is this a strategy that you'd like to be able to offer to your patients now? And that's another thing. You can always offer it to the patient. You don't have, necessarily recommend it, but just make them know it's a possibility. But how do you see this, Giuseppe?
Well, I believe implementation of SERENA-6 in the real world is something feasible. My decision will be patient-based, so I would discuss with the patient explaining that sometimes you may have a molecular progression without a radiological progression, and you have the probability to switch. And since these are patients in the metastatic setting, I have to confess, despite the discussion of Angela Di Michele, that many patients prefer to know and to perform the liquid biopsy. Because if they are in the metastatic setting and they believe that a test can intercept the progression, they prefer to switch as soon as possible treatment. This is not the case in the adjuvant setting, but in the metastatic setting, I can guarantee many patients asked to be enrolled in the SERENA-6. The main limitation of the study, in my opinion, is the absence of crossover in the control arm when there was the radiological progression. Because I would accept also a near equivalence or non-inferiority in a design like this, but that is a potential limitation that will limit the use. But to answer your question, I would use it discussing with the patient.
So, Priyanka, I want you to take a look at this case. This is actually a patient that went on the SERENA-6 study. And I'm going to let Giuseppe talk about what happened, then ask you, looking back, if you were to see a patient like this today, whether or not you would offer it, maybe not recommend it, but at least bring it up to the patient. But anyhow, Giuseppe, what happened with this lady?
This is a de novo metastatic breast cancer patient. This is really important, of course, because endocrine sensitiveness is very high. So she performed this core biopsy, finally, discovering an HR-positive, HER2-negative disease. And finally, she started with AI plus palbociclib in the metastatic setting. Don't forget about this. And once she started at the beginning of 2023, I proposed to be screened in the SERENA-6. Next slide, please. And so she started in March 2023. And we did the first test after 1 year. This is really important. After 1 year, ESR1 mutation was not detected. If you remember the date of the SERENA-6, the majority of the patients have been detected after 18 months of exposure. So what I did, after 6 months, I tested again for ESR1 in September 2024. And there was an ESR1 mutation without a radiological progression. So here I wrote a switch to camizestrant. The trial was double-blind. So the hypothesis is that she was receiving camizestrant because joint pain, fatigue, any symptom related to the aromatase inhibitor disappeared. And so the quality of life of this patient dramatically improved. And once she did a switch to camizestrant, she's still on treatment. Finally, in October, I did a CT scan in the clinical trial. There is no radiological progression, and she's still on camizestrant.
So, yeah, people brought up the fact that maybe some of the quality of life improvement is just going off in AI to go into a better tolerated SERD. But I'm just kind of curious, and also maybe you can comment on out of this patient's attitude. If it was today and there wasn't a clinical trial available to her, I'm just kind of curious, Giuseppe, is she the kind of patient you think would, if she had it explained to her, would choose to go on this path with ESR1 positivity leading to CAMI? Or do you think she would say, no, let me just stick with what's standard? How do you think she would respond today?
Knowing the patient, she's a patient that would like to know if there is a mechanism of resistance ongoing on the current treatment. Not all the patients are the same, but this is a patient that for sure would accept this strategy.
Well, also, she went on a trial, which kind of tells me she's more proactive in general. Priyanka, again, if you were to see a patient like this today, would you, if it was approved and you could do this, would you offer it to her? But you could offer it to her and say, hey, maybe you should not think twice about this because the trial had things that could have been better. Or would you present it if she wanted to do it? Would you treat her?
I think the first challenge we have to figure out is when do we start testing, right, these individuals with ctDNA, and, that might be helpful from the trial. My take would be if they're doing very well on the current treatment with very minimal toxicity, I don't know that I could probably salvage this at the time of radiographic progression with our other available SERDs, right? So it's not like we don't have other drugs to give to these patients. Giredestrant plus, everolimus would be a good combination. So I might discuss it with the patient, but my enthusiasm may not be as high as Giuseppe's. Because we have other SERDs that are available, and especially we can give them in combination now as they get approved.
That's what I call the art of oncology. Okay, let's talk about another challenging situation. Now it's been just about a year since last San Antonio, where we saw the EMBER-3 study that led to the recent approval in the United States of imlunestrant. But also we saw in that trial an arm looking at imlunestrant plus abemaciclib. And at ESMO, we saw some interesting follow-up. One of the points that was brought up about the EMBER-3 trial was there was not a control arm of abema and fulvestrant. And Giuseppe, this was an attempt, it kind of reminds me, I remember when Dr. Hal Burstein did the discussion of EMBER-3, he showed the indirect comparison of PFS of the various trials of SERDs, and then this trial where you saw like about a 9-month PFS with the combination much higher. But here they tried to do an indirect comparison, looking at the 3 major trials that looked at abema. So you have the EMBER-3 study where we were talking about this issue of the combination, Monarch 2, first-line metastatic, and then the post-Monarch using abema in patients with prior treatment, trying to see indirectly, and it did look indirectly. You can say this just based on looking at the PFS, but when you looked at these curves, I'm curious, Giuseppe, what your thoughts were about this paper. A lot of people get all upset when we start doing indirect comparisons. On the other hand, sometimes that's all you have to work with. We saw the forest plot, all 3 of these trials kind of showing better effects with the combination. What was your thought about this, Giuseppe? And what's your thought about imlunestrant and abema or SERD and CDK in general?
But, first, you cannot do cross-comparison across trial because methodologically is not the right way to move. But coming back to your question, I believe the combination of imlunestrant and abema is very interesting, in my opinion. Of course, the comparator arm was imlunestrant alone. That was not a standard of care. But if you want to extrapolate, imlunestrant is a me-too of elacestrant. Here we can see in the trial that imlunestrant was superior to fulvestrant in ESR1 mutant only, was not superior in the intent to treat population, but the combination of imlunestrant plus abema was really effective independently of ESR1 mutation. I believe this combination, if available, can be really a breakthrough combination because you can treat a patient with an oral SERD plus a CDK4/6 inhibitor without testing for ESR1 mutation. That, in my opinion, is really important as an observation. And you can do this in the post-CDK4/6 inhibitor setting, so it's much more important. So I believe that overall, in the future, oral SERD will be more important in the adjuvant setting. But in the second-line setting, heavy combination of oral SERD with a targeted agent can be breakthrough. We saw the data giredestrant plus everolimus. We have the data imlunestrant plus abemaciclib. So why not combining finally? Because you can improve the outcome of our patients, and maybe you can expand the use of the oral SERD to all the patient population. And oral SERD may work also in ESR1 wild type, not only in ESR1 mutant.
So, Priyanka, before I ask how you're thinking this through and what you'd like to be able to do in your practice, I'm going to, again, show you what some of your colleagues think about this. So, again, this is the general medical oncologist. We said, are there situations, would you like to be able to use a combination of imlunestrant and abema as first-line treatment? And more than half of the general medical oncologists say yes. Then we say second-line treatment, now it goes up to 2/3. But actually, in the investigators, we saw even more positive responses or interpretation of this. 16 out of 20 say they'd like to be able to use it in a first-line situation, and all 20 said they would like to be able to use it in second line. So, Priyanka, what are your thoughts about this kind of strategy and where it fits in?
Yes, I mean, I do agree that the combinations are a lot more robust than monotherapy for SERDs, and they perform better if we can institute them before you are 3-4 lines down and rank radiographic progression. Also, we have to remember that in ESR1 wild type, the SERDs were not better than fulvestrant, but they were not worse either, right? So we use our fulvestrant regardless of ESR1 mutation. So if we can use a SERD with a combination more robustly, regardless of ESR1 mutation, then that makes sense. It might be relatively a little bit more effective in presence of ESR1 mutation, but it's not ineffective in ESR1 wild type.
And of course, there are trials looking at SERDs in the adjuvant setting. At least there, one thing, hopefully if it was equal, thinking back to Giuseppe's patient, maybe it'll be better tolerated, more adherence. You might see more benefit just because of greater adherence because it's less side effects. So Giuseppe referred to this much anticipated study that was presented at ESMO, the phase 3 ERA trial. This is looking at a SERD, a new SERD, not approved giredestrant, but in combination with everolimus. So you want to take a look at that. Also, another study looking at giredestrant. This very interesting in premenopausal women who are not having ovarian suppression, comparing what you see preoperatively, window of opportunity, compared to tamoxifen. So in terms of the phase 3 EVE-ERA study, maybe you can just comment a little bit about who got in the study, Priyanka, and pretty impressive outcome data here with a hazard rate of 0.3 and a PFS in the range of 9 months. Again, similar to what we saw as Giuseppe was referring to in the EMBER-3 study. Anything you want to say about this study, Priyanka, and what you think it means in terms of clinical practice?
So it's for post-CDK, so our classic post-CDK study, and 2/3 of the patients, they could have had 2 prior lines of endocrine therapy, but 2/3 were 1 prior line, so really proximal to their last CDK inhibitor. And impressive response rates, and the toxicity that we saw was mainly the toxicity we see with everolimus, right, the mucositis and the everolimus-associated toxicity. That drug's been around for a while, and we have a much better understanding of how to effectively use it and manage toxicities for our patients. The efficacy was higher in the mutant as opposed to the non-mutant population, relatively so. But again, it was not ineffective for the non-mutant population. There was improvement in outcomes. What we didn't see is the ESR1 wild type, right? So that hopefully will come. It wasn't a pre-planned analysis. We just saw ESR1 mutant and ITT.
Yeah, you see that in a lot of these SERD trials. You see either ESR1 mutant or everybody, and everybody wants to know, well, what about the wild type? That hazard rate I talked about before was in the ESR1 mutant patients. Before I come back to Giuseppe for his thoughts about that, I also want to bring up this window of opportunity trial. Again, really fascinating to use this agent in the premenopausal patient. Really pretty impressive looking waterfall plots. And tamoxifen, pretty good waterfall plot, but looks like maybe better efficacy with this is now giredestrant monotherapy. So before we get into Priyanka's case, just Giuseppe, any thoughts about giredestrant, where you see it heading? Would you like to be able to use it with everolimus right now?
Personally, yes. Of course, if you have the opportunity to use a combination therapy in the second line, with a combination at no cost, because everolimus is a generic drug, actually. So you don't have additional cost and you know how to manage toxicity. So 9 months of median progression-free survival are overlapping with the 9 months of imlunestrant plus abema. And I believe it's a good option for our patients. I am almost sure this combination will be approved. And now, don't forget, we have 4 oral SERDs: imlunestrant, giredestrant, camizestrant, and elacestrant. And so now the scenario is complete, and this means that the best option will be the best combination in the second-line setting. Because as a monotherapy, the activity is clearly overlapping across them. I don't believe one is better than another one.
And even though you do hear about some differences in tolerability, I kind of get the feeling that they're all extremely well tolerated, so that may not be easy to differentiate. But again, I'm not sure how much monotherapy is going to be used in the future. So Priyanka, you actually have a patient who looks like they actually went on the study and got giredestrant plus everolimus. And interesting, because when I saw the mucositis in that study, I was thinking, well, maybe that was ex-US. Everybody in the US knows how to deal with mucositis with everolimus. But in your hands, this patient sounds like she still has some pretty significant problems, even though was she actually using the prophylactic steroid mouthwash or not?
So we prescribe it, we instruct everybody to use it, but oftentimes it's just something that patients forget. You're doing fine. Like you'll use it for 3 days, you're doing fine, and then you stop using it, right? And then the mucositis shows up. It's usually you can manage it with dose reduction, which we did, and then more education that you've got to use it. Otherwise, the mucositis will come back. And once you get through the first 3 months or so, it's really not an issue. I do want to point out that the everolimus was at full dose, right, that we use otherwise with either as monotherapy or with fulvestrant.
All right, so we're going to talk about AKT targeting next. We saw a couple of interesting papers. First, some follow-up on capivasertib and the phase 3 Capitella 291 study, looking at a subgroup analysis, similar to what we were talking about before. It looks like any subgroup you looked at, you still saw the same benefit that was seen previously that's causing people to use this agent. I wanted to just kind of also use this as an opportunity to see what your thoughts are about using capivasertib in clinical practice. I was mentioning about this thing with prostate cancer. We're actually doing a symposium now at the GU meeting on AKT inhibition in prostate cancer, so that's going to be a whole new avenue for us to deal with. But in terms of what we have to deal with now, Priyanka, one of the issues here is what are people actually doing? And this I thought was pretty interesting because we've consistently seen ever since Capitella came out that the investigators stopped using alpelisib. But when we asked the general medical oncologist, interestingly, we still see a significant minority of general medical oncologists, a PIK3 mutant situation, using alpelisib. Investigators, we see almost complete use of, you don't see alpelisib, like 1 out of 20 people would use it. So maybe a little bit of a gap there. I'm curious how you approach the use of capivasertib, Priyanka, in your practice, particularly what you see in terms of toxicity and how you ameliorate it.
So definitely Capiva is better tolerated than alpelisib, and some of it has to do with the intermittent dosing schedule. So the hyperglycemia, rash, and other things are better with that dosing schedule. So I've primarily switched to the Capiva as opposed to the full alpelisib combination when I'm giving this drug. You still have to monitor the glucose, check A1C, and some of these patients will still require institution of metformin or other antidiabetics, even on Capiva trials.
Anything you want to add to that, Giuseppe? What's your experience? You see a difference in quality of life when the patient's on the Capi versus when they're off it?
Usually, yes. With inavolisib, it's more common to have a higher rate of hyperglycemia. It's more on target. So you need really to use, in many cases, metformin and to change the diet of the patients. You may have also diarrhea. With capivasertib, of course, you may experience similar diarrhea and cutaneous rash, but less hyperglycemia. I would like to remind that with all these agents, it's really essential to do a lot of patient education. So you have to sit down with the patient to explain the side effects, because this is the only way to increase compliance and to increase adherence. And don't forget that these patients may be at risk of losing weight also, because these drugs can induce weight loss.
So I'm very excited. This summer we had the opportunity. I was doing something I really wanted to do, which is to do ophthalmology for the medical oncologists. And we just got approval to do my other fantasy, which is diabetology for the medical oncologists. I can't wait to do that, because particularly as it relates to these drugs, it's a very interesting issue that comes up in terms of glucose tolerance. So Priyanka, I want to get your thoughts also about another agent in the PIK3 pathway, inavolisib, which is now approved as a triplet first-line therapy with CDK and endocrine therapy. We're talking about combination therapies, and at ESMO we saw this. I think it was just a poster, but really interesting look at. We just talked about giredestrant now with inavolisib, so SERD and AKT, and of course this is a small phase 1-2 study, but pretty interesting. They're starting to see responses here, which, I think is interesting, in the 16% response rate in these patients. Any thoughts about this combination, Priyanka, in terms of the potential for, I don't know if it's going to be looked at in a phase 3 setting. It seems like there are a lot of combinations now. And also curious about your experience with inavolisib and in the first-line situation, what you see in terms of efficacy and tolerability.
So I think, this is the logical next combination for a SERD, I would say, like in second-line setting. If a SERD we think is better than fulvestrant in most of our patients, especially in those with ESR1 mutation, then these drugs are better partners for our PI3 kinase AKT inhibitors, which come in the second-line setting. Inavolisib requires a lower hemoglobin A1C to start, like less than 6, so it's even stricter for glucose starting point. It has the same side effects, I would say, that we experience with others: the fatigue, rash, diarrhea. For us, where obesity is high, hyperglycemia. You can have many patients that have good-looking A1C, and the minute you put them on these drugs, the glucose just goes totally out of control, and they're in the hospital with DKA. So we have to be really, really watchful and cautious. It's a very effective combination, improvement in OS, right, in the setting of early progressors. So I endorse using it with all the right safety and support measures.
So also curious, Giuseppe, what your thoughts are about this combination, and also how you've been thinking about using capivasertib. Any thoughts about this combination, Giuseppe?
I personally believe that in endocrine-resistant disease with the PI3 kinase mutation, this triplet combination, fulvestrant, palbo, inavolisib, would be my preferred combination. So what is really important here is to don't forget to test for PI3 kinase, because the only way to get this triplet combination is to test for PI3 kinase. That cannot be tested only on the liquid biopsy. It should be done also eventually on the primary tumor, because these are patients in the first-line setting progressing during adjuvant endocrine therapy or within 1 year after the end of adjuvant endocrine therapy. So don't forget, perform NGS, tests for PI3 kinase. In the clinical study, they were around 41%. Patient positive. In the real world, they can be between 35 and 40%. But if you don't test, you cannot give inavolisib.
Yeah, I think it's a very important message, because at ESR1, you're thinking, you're not going to see that first line, but PIK3, you are going to see it, and we have data to support it. And here's a good example. A 65-year-old patient who got the inavolisib triplet with palbo and fulvestrant, I think off trial after it was approved. I'm really curious, though, Priyanka, exactly how she did. It looks like she had issues with rash. It looks like her glucose control was pretty good. She starts out the hemoglobin A1C that goes up a little bit to 6.9. You put her on metformin. Generally speaking, how did she do and what kind of issues came up? How bad was the rash?
So the rash, when it comes, it's bothersome. Like even if we grade it lower, it's bothersome and it's itchy. So I do take a break for a few days from the drug, and antihistaminics work well. Other thing that I have noticed is if the patients can avoid being in hot, humid environments, that helps. So don't go out and sit in a baseball game outside for many hours, middle of the summer. That helps. The glucose was up, so we started metformin. We have to be watchful. Diet management, diabetic. I usually send my patients to get diabetic diet counseling, so they can watch the carbohydrates that they eat. In spite of all of this, she's still losing weight. When you put patients on metformin, one thing you have to be careful of is it can cause diarrhea. So if somebody's already having little grade 1-ish diarrhea from Inavo and you put them on metformin, that might get worse. So again, more education and counseling is helpful.
So, and we saw, as soon as the data was presented, that the investigators started to use, as soon as it was approved, people were using this triplet. They were looking for PIK3 in the first line setting and using it if they found it. I'm just going to briefly comment on the Victoria study. It's another AKT inhibitor, gedatolisib, in combination with fulvestrant and palbo, that was also presented by Dr. Hurvitz. The patients that were presented here, I think, were the ESR wild type, where they still saw benefit, pretty significant benefit. Priyanka, anything you want to say about the Victoria 1 study?
So this is an interesting agent because it's a PI3 kinase AKT mTOR, so it goes all the way down, and the side effect profile actually shows that. And the cohort that was presented was the PI3 kinase wild type cohort, and quite impressive activity of the triplet, also good activity of the doublet, but quite impressive activity of the triplet combination in these patients. It was also not untoxic, especially with the oral side effects and rash and diarrhea. It's an IV schedule, so that's the major issue with this. It needs to be given IV 3 out of 4 weeks. So that may produce different type of challenges in clinic.
Yeah, that sounds like that might be a significant obstacle, but we'll see. I guess it depends on how good this data looks at moving forward. So another paper I want to get your take on, and we already have 2 TROP2 directed ADCs approved in breast cancer. These are data from a third one that's been mainly looked at in Asia, I believe. We call it SAC-TMT for short. This is a phase 3 trial in ER-positive patients. Again, we have both approvals with Dato and sacituzumab, but we saw this data. I'm curious what you thought, Giuseppe, of SAC-TMT in terms of, again, we were kind of forced to indirectly compare to what we've seen with Dato and sacituzumab in the ER-positive population, hazard rate of 0.35 for PFS. Kind of a slightly different profile, toxicity, not exactly like Dato, not exactly like Saci. I don't know, Giuseppe, whether you've actually used this agent. What are your thoughts about it and its future?
No, I am using it in the context of clinical trials. I believe it's an interesting anti-TROP2 ADC. Sacituzumab tirumotecan potentially can be approved both in triple negative and HR positive disease. In my opinion, what I like about this drug is less incidence of diarrhea. This is really important because even if you have a similar target antigens, TROP2, a similar payload, a topo-1 inhibitor, the safety profile is completely different. As you know, both the trials in triple negative and HR positive have included the majority of the patients in Asia, but actually there are ongoing 2 trials in the Western world, one for the triple negative disease in combination with the Pembro, and another one in combination with Pembro for HR positive disease. So personally, I believe we need to better understand the safety profile in the Western population, because, pharmacogenomics of Asian, when you manage topo-2 inhibitors, is a little bit different from Western. If you check the subgroup analysis in the studies, of sacituzumab govitecan, this is very clear. So I like this drug, potentially active, potentially another new ADC in breast cancer.
All right, well, I'm really curious about how you're thinking through current management of ER positive, let's say HER2 negative disease, but including HER2 low in patients who exhaust endocrine treatment. You're ready to move on to something else. We were going to pull one of these algorithmic type slides, but I just sort of listed in an open-ended way how you think about sequencing in the ER positive HER2 low patient, Priyanka, and how you think about sequencing in ER positive HER2 zero patient. I don't know if there are any of those left anymore, but let's just say we do have that. And certainly in the HER2 low situation, let's start with that because now you have the option of TDXD. You also have two approved TROP2 agents, sacituzumab govitecan and datopotamab deruxtecan. You also have capecitabine and other chemotherapy as potential options. And then down below, I listed some of the things I think people think about when they try to figure out how to sequence these things. You know, performance status, comorbidities, are there tumor-related symptoms, visceral, CNS disease, what they've had previously. Bottom line, Priyanka, how do you think, I guess one big question is TDXD versus TROP2 ADC. What comes first, and what comes first among the two ADCs, the two TROP2 ADCs?
So I think for HER2 low disease, obviously we have the DB06 data, that a trial that compared TDXD to other chemotherapy of physician's choice in the first line setting, and TDXD was superior. And so that is an option for most of our patients with HER2 low disease. Having said that, I'm not sure it's an option for every person. Capecitabine is still a really good drug, very well tolerated, good quality of life. For HER2 low disease, if I'm going to use an ADC up front, it is TDXD, not SG or Dato, because that data is more further down the line. And we've recently seen a press release from ASCENT-07, which was the first line SG versus chemotherapy of physician's choice trial in patients with hormone receptor positive disease that did not meet its primary endpoint of PFS. Of course, we haven't seen the data. For HER2 totally negative disease, I think we don't have first-line SG or Dato data yet, so those patients may still be getting CAPE or taxane, and then followed by either one of the two TROP2 ADCs. If a patient's had prior pneumonitis from any of our targeted endocrine drugs, then I'm a little bit more careful when I'm thinking of TDXD or even Dato that has small risk of pneumonitis.
So, Giuseppe, let's go back to the HER2 low situation. And also, we can comment on HER2 ultra low, that you presented. And do you approach a patient with HER2 ultra low different than HER2 1 or 2 plus? And particularly, again, assuming you have all things available to you, how do you decide between TDXD and TROP2? And if you're going to use TROP2, how do you decide which one? And would you use TROP2 after TROP2?
But now it's more easy because the HN7 is negative. So the first line treatment would be for sure trastuzumab deruxtecan, because don't forget that HER2 ultra low is ASCO-CAP 0 formally. So, I would give TDX for sure after progression to one or two line of CDK4/6 inhibitor, even if we still don't see the data on overall survival. I would give as a sequence between two ADC, usually a chemotherapy. I don't like to give an ADC after an ADC because ADC2 usually have a very short median progression-free survival. So I prefer, let's start with an ADC entire two, then I give a chemotherapy, and then I will give an anti-TROP2. And don't forget that all the anti-TROP2 have been tested after 2 or 4 lines of previous chemotherapy. So until we don't have the data of sacituzumab tirumotecan in the same setting of DESTINY-6 alone or in combination with the pembro, actually I prefer entire 2 first, anti-TROP2 later.
So again, assuming equal access, Giuseppe, let's assume you're in a situation where you want to use a TROP2 ADC. What are the factors that you consider in whether you're going to choose sacituzumab versus datopotamab in terms of pre-existing comorbidities? number of visits to the clinic, other quality of life issues? How do you decide between the TROP2 ADCs? Which comes first?
My first driver is the magnitude of clinical benefit. So if I have a median PFS improvement that is better and potentially also an overall survival benefit, my selection will be based on this. Up to now, when I have to select an anti-TROP2, the schedule, in my opinion, is important because, coming back on day 8, to have another injection can be an issue for many patients in my country. And finally, overall survival is the driver. So if you are asking me which one of the two you would select, the one who demonstrated an overall survival benefit.
So also I'm curious about how you manage patients on these TROP2 ADCs. Let's start out with Dato-DXd because it's newer. Just approved in breast cancer this year in January. So Priyanka, can you talk a little bit about how you think through preventing and managing tolerability issues with Dato, particularly the issue of mucositis?
So yeah, just like other drugs that cause mucositis, requires a lot of education. The steroid mouthwash prescription, keeping ice in mouth during the infusion of Dato helps too. So that we've been doing as part of trials. And then ensuring that patients stay on those mouthwashes and follow there's a whole oral care instruction that gets given, brush after every meal, and it's involved. Like the patients have to be invested into it. The other aspect is the eye care, right? All the trials required ophthalmologic examination before starting, detailed with slit lamp and everything. And then intermittent exams during the treatment. Many patients cannot wear their contact lenses when they're on Dato. Even if they have mild eye irritation, it tends to make it worse. And the eye drops many times a day. So, both of them have different types of burden that it brings to the patient. I would say neither one of them is burden-free.
I'd like to get your thoughts on these two issues she just brought up. Priyanka brought up the mucositis as well, the ophthalmic issues. I was mentioning we did this program with an ophthalmologist this summer, and and I've heard from other investigators, people kind of feel like it's not as big of an issue, the eye issue, as it is with some of the other agents, mirvetuximab in ovarian cancer, and also in myeloma, we have belantamab that just got approved. But it seems what I've been hearing is that much less ophthalmic issues. I've even had people say that they don't necessarily even send the patient to an ophthalmologist unless they have problems. They're using the steroid drops, et cetera. So I'm curious what you've observed and what you think about the ophthalmic issues with Dato. Giuseppe, do you send all your patients to an ophthalmologist? And also what your experience is with mucositis.
Regarding ocular toxicity, what we do in practice is to perform a baseline assessment to better evaluate if any risk factor can be present in that patient. Now we have a multidisciplinary board discussing about ADC toxicity, pneumologist, diabetologist, ophthalmologist. So baseline assessment, starting eventually preventive therapy, eye drops in case there is a potential risk, and then assessment every time the patient is referring a specific symptom. What is important with ocular toxicity is to avoid to have a symptomatic toxicity. This is really essential because if you have a symptomatic toxicity, you have to stop the treatment. Regarding the second question, I do exactly what Priyanka is doing. So using ice during the infusion and using the steroid mouthwash. This is really important to be done because now, as you know, datopotamab is under development in combination with pembro in the triple-negative disease. And when you have a combination therapy, you have a higher risk of mucositis. So patient education and prevention strategies is the best way to avoid, finally, to treat these patients and to discontinue the treatment.
So also a word about sacituzumab in terms of tolerability. Priyanka, of course, it's been out there much longer. Most oncologists haven't even used Dato in breast cancer yet. SASI's been out there for a while. We have seen data that suggests that people get preemptive growth factors and preemptive antidiarrheals have less issues with those particular toxicities. Are these strategies, do you use these preemptive strategies? How do you deal with the issue of cytopenias and also GI toxicity, diarrhea?
So I'm pretty prompt with the growth factors. In patients who have had prior issues with blood counts where I anticipate they're going to have issue, I try to do preemptive growth factor on day 9 if the insurance will approve it. I give the antidiarrheals for patients to have at home with strict instructions that they need to buy it and have it at home before the first dose. You cannot run to the bathroom at 2 a.m. at night when you're having, you cannot run to a grocery store at 2 a.m. at night. And typically, we can manage it with antidiarrheals, dose reductions, other types of things, right? There's some patients who have it very severe, and you have to switch the drug because of that. So as I was saying, I think both the drugs require patient engagement on different types of things, right? And it just depends on what the patient protoplasm is for different things.
All right, well, let's talk about papers from ESMO focusing on triple-negative disease. Mostly we're going to talk about metastatic disease, but I am curious, Giuseppe, what your thoughts were about the GEPAR-NOVA trial that was presented at ESMO looking at durvalumab in the neoadjuvant triple-negative situations. This is long-term data. This is a phase 2 study, so not the same as 522 with pembrolizumab. But the interesting thing here is they saw really great results using chemo plus IO neoadjuvantly, but they didn't use adjuvant therapy. They still saw significant benefit. And, I don't know that a phase 2 study is going to be enough to change practice, but kind of it almost has a little bit of implication in terms of the current use with pembrolizumab. I hear people, Giuseppe, talking about looking at cell-free DNA to try to make the decision about whether to keep the IO going in a patient who's had a path CR. How do you think about this, and what are your thoughts about this phase 2 study with durvalumab?
So the GEPAR-NOVA trial was a window of opportunity in neoadjuvant treatment. The primary endpoint was PCR, and the trial was negative because it did not meet the PCR endpoint. So this is important. What we can learn from the GEPAR-NOVA, and this is very clear for oral disease, if you have to give an immunotherapy, it's better to give in the neoadjuvant setting. And this has been demonstrated for melanoma, very clear with the NADINA trial, for lung cancer. So it's better to give an immunotherapy when the tumor is there, because this will increase the probability of having a PCR and to cure the patient. What is not answering the GEPAR-NOVA is whether to give or not post-neoadjuvant immunotherapy. So GEPAR-NOVA, it's not enough to omit post-neoadjuvant immunotherapy, and there are 2 trials ongoing that will address specifically this question. So investigational trial, negative trial, interesting data on the role of neoadjuvant immunotherapy in triple-negative disease.
Quick follow-up, Giuseppe, any thoughts about cell-free DNA to try to decide whether or not to use IO in the post-neoadjuvant setting? Of course, everybody's using cell-free DNA in colorectal cancer, and now we see it in many different solid tumors. Any thoughts about whether it might at some point have a role here?
We have 2 studies, one for BRCA mutant, another one for BRCA wild type. I would like to remind to the audience that if you have a ctDNA positivity after neoadjuvant treatment surgery, this is a big issue because the probability to develop a metastatic disease within 6 months is very high. So I don't believe ctDNA in the post-neoadjuvant setting should be, let's say, a potential inclusion criteria to give an immunotherapy. So we need new agents, more active agents, eventually to treat this new patient population that is the ctDNA positive after neoadjuvant therapy, that is with a very poor prognosis, just to remind. The CTRAC triple negative was completely a failure because the majority of the patients were already metastatic, and the trial with the PARP inhibitor was exactly the same. So for this patient population, we need more active strategies.
All right, well, let's shift to metastatic triple-negative disease, where we did see some major, I think, probably practice-changing data. The use of ADCs. We saw at the ASCO meeting the ASCENT-04 study looking at sacituzumab plus pembrolizumab, and we knew there was a press release out there of the companion study, ASCENT-03, looking at patients who were not eligible for PD-1 inhibitors. And no huge surprise here. We also saw a significant benefit here. Priyanka, any thoughts about what we see here in this study comparing sacituzumab to chemotherapy? You know, throughout solid tumor oncology, time and time again, we see ADCs outperforming chemotherapy. And, you know, it's kind of the original premise of ADCs in general, that you would see greater benefit. Sometimes you see better tolerability or different tolerability, but here it is again. You do see a benefit, at least in terms of PFS. Any thoughts, Priyanka?
So yeah, we were all hoping to see this result. So better efficacy compared to chemotherapy of physician's choice. In this trial, about 30% of patients had de novo disease, and about 18% or so had recurrence between 6 and 12 months from their curative therapy. And, you know, modest improvement in PFS, and no new signals from the safety point assessment. So I think this definitely is practice changing for our patients, just like ASCENT-04 was for patients with PD-L1 negative disease. Less treatment discontinuation due to cumulative toxicities, which we certainly start seeing with the taxane-based regimens.
So, and we'll get to the fact that now, instantly, not only do we have ASCENT-03, but we also have a trial with Dato, so we're going to have to sort that out in a second. But first, let's just stick with ASCENT-03. And just kind of curious, because you brought up the issue before, Giuseppe, that maybe when you add an IO to an ADC, maybe you're going to see more toxicity. What about when you add an IO to sacituzumab? I guess one thing I was thinking is you can see diarrhea with both. You know, you can see immune diarrhea, colitis, et cetera. It didn't really look like they saw that. Any issues there in terms of this combination? And again, Giuseppe, is this something you'd like to use in your practice?
You know, still the combination of Sashi and Pembro is not approved in Europe. I used it in clinical trial, of course. I am using also datopotamab plus durvalumab in clinical trials. You know, patient education and starting appropriate treatment as soon as possible is the major recommendation. Sometimes you need to understand if diarrhea is more related to the ADC or more related to the immunocheckpoint. So doing an appropriate diagnosis is essential because you start a different type of treatment. So we have to be careful on this.
All right, so just to make it a little bit more complicated, here's the conclusions of ASCENT-03 as a potential new standard of care. We also saw ASCENT-04. We'll get to the data study in a second, but this is more data than the trial that Dr. Taleni presented at the ASCO meeting, again, in the PD-1 positive patients. This one, again, looking at follow-up data in terms of patient-reported outcomes. I think no huge surprise that we did see improvement, for example, in terms of deterioration in physical function, and the conclusion being that, you know, it looks like it maintained quality of life and perhaps was better than with chemotherapy. But let's get to a case first before we get to the Dato study, because this is a patient who got, I guess, the ASCENT-03 strategy that was again presented at ASCO, 52-year-old African-American woman who got neoadjuvant Keynote 522 that we were talking about, and then at the time of surgery had significant residual disease, one positive node. She gets adjuvant capecitabine along with adjuvant pembrolizumab, along with radiation therapy. And then a couple months later, just 2 months later, she has skin metastases, CPS less than 10, now also some new liver lesions. So she started on sacituzumab. So this is, I guess, the ASCENT-03 strategy because the PD-1 there is negative. So can you talk a little bit about what her condition was when she started the sacituzumab and then what happened there, Priyanka?
She had still a pretty good performance status, and we're starting to see a lot more of this now with our adjuvant pembro and the length of time for curative therapy for triple negative patients. That the recurrences appears to be happening in much more closer proximity to the curative adjuvant therapy, which is classically in her case. And she'd already received all the active drugs in the curative therapy in less than a year and a half ago. So off trial, I was able to get sacituzumab for this patient. She wouldn't have been eligible on ASCENT-03 because you had to be at least 6 months. And ASCENT-03 and 04 were done at the time where curative pembrolizumab was not standard of care in many places. So very small proportion of patients there got adjuvant or neoadjuvant pembro. So she's, tolerated it with expected side effects, and it is working. We'll see how long it continues to work.
It looks like she's responding also. So Giuseppe, one thing I thought about actually more when I saw the data at ASCO, I always get the numbers mixed up. I guess that was 04 with the pembro, which is like, for example, this patient, if she was PD-1 positive, would you, first of all, in general, what are your thoughts about SASI plus pembro? I think you said you think it's a reasonable option. But what about patients with prior treatment with 522 who've already had an IO? Giuseppe, how are you thinking through that?
No, if you have a relapse within 6 months after the end of adjuvant treatment, these are patients with a very poor prognosis. We have also some data on this patient population. This is really an unmet medical need. So here I completely agree with the selection of the ADC, but for sure I will not give an immune checkpoint inhibitor with chemotherapy. So we need to understand if in this patient population an ADC plus immunotherapy can be a reasonable option.
What about the patient who has previous therapy, but it's been, let's say, 2 years or 3 years since they had it?
Yes. In this case, I would test again for PD-L1, and for sure I would use again an immunocheckpoint inhibitor. So for this specific patient with the long disease-free interval, my answer is yes.
So Priyanka, in the chat room, Divya says that she has a patient just like your patient. And what comes after SASI? If your patient were going to progress, what's next? Maybe you can help Divya out.
I mean, as Giuseppe said, these are really bad biology, and I would look for a trial after SASI for targeted drugs. I think another class of drugs that might have future promise here is the dual antibodies, bispecific, that address both VEGF and PD-1 or PD-L1. These are bad tumors. Typically, they are low proliferating, have low TMB, but just very aggressive.
That's interesting about that bispecific. We were just talking about that in the lung cancer program the other day. Very interesting. Everybody wants to know, is that like the same as given Bev plus chemo? But anyhow, it's a bispecific. Always loved bispecific. All right, now it gets even more complicated because at the same time we're seeing this SASI study, we also saw TROPION-Breast02, again in the metastatic first-line triple-negative situation, again similar to the SASI study where IO is not an option. So Giuseppe, can you talk a little bit about what they saw here? Again, how it indirectly compares to what you see with sacituzumab, and assuming you have both options available, how are you going to think through which option first?
I believe the two ADC are good ADC. Of course, we have a different study design here because in the TROPION-Breast02, crossover was not allowed. In the ASCENT was allowed, and that's maybe why you have not exactly the same benefit in terms of overall survival. The TROPION-Breast02 clearly demonstrated that there was an improvement in median progression-free survival, a better response rate. This surprised me. And finally, also a trend for overall survival. But what if in the control arm, patients in the TROPION-Breast02 were on sacituzumab govitecan? That was not allowed here. So for me, these are two excellent ADC. Both of them are good option. Of course, if I have a patient with inflammatory bowel disease, I am going to give maybe datopotamab. And if I have a patient with ocular problems, maybe I am going to give sacituzumab. If the patient is perfectly fit, I would discuss with the patient the schedule, because you know better than me that the schedule of datopotamab is every 3 weeks, and the other one is 1/8, and then again 21. So two good agents, patient preference if you don't have comorbidities to select one versus another. If you have comorbidities, of course, the patient profile will induce me to select the best one.
So it sounds a lot like what we were talking about before in ER-positive disease, trying to assign between Dato and sacituzumab. All right, let's get into one final case here from Giuseppe, a 58-year-old woman, family history with a mother with ovarian cancer. What happened? It looks like it turns out she has liver met. She's ER negative, HER2 1 plus, PD1 negative. Looks like she got datopotamab. What happened, Giuseppe?
So during datopotamab, despite the incidence of ILD is lower, she developed an ILD. So she had an excellent response to datopotamab deruxtecan in the clinical study. Next slide, please. But during the treatment, so this is the response, next slide, an important response rate. But during treatment, she developed a G1 ILD. So she was asymptomatic, but during the CT scan restaging, we discovered this area in which there is a clear an ILD. And so what to do now? Of course, when you have an ILD with no symptoms, you need to perform a pulmonary function test and pulmonologist consultation, and you need to start, of course, a treatment with dexamethasone at the same time also with antibiotics, because maybe there is a risk of an infection. But you can see here that she had an excellent response to the treatment. And then what we did, of course, here there is an error. We restarted again datopotamab deruxtecan, because if you have an ILD grade 1 with a complete resolution, you can start again the same ADC. This is an example. We discuss every time about mucositis for datopotamab, ovular toxicity, but you may have also ILD. In the clinical trial, 7 patients developed a grade 2 ILD in the study. Yes.
So I want to just come back to you, Giuseppe, though, and ask you kind of a basic question. I'm a simple person. So if we're going to say over here is the risk of ILD with TDXD, and over here is the risk of ILD with CDK inhibitors and many other drugs that we use in oncology, like where does Dato fit in terms of risk of ILD? Is it closer to what you see with a lot of agents, or is it more increased in the realm of TDXD? Obviously, this is indirect, but I'm just curious.
For me, it's closer to the risk of ILD induced by CDK4/6 inhibitor. It's very low, the probability, very, very low. Yes.
But it's interesting, though, that you applied the TDXD algorithm for managing ILD, and I wonder, like, for example, Priyanka, this algorithm of, treating a grade 1 with steroids, and maybe we saw retreating being safe. Do you do that strategy if you have a patient on another agent? Is that the way you approach ILD right now?
With ADCs, yes. That's the approach I take. With ILD with oral agents, doesn't resolve as rapidly as we see with ADCs, even with steroids. So there I'm more cautious, and often you have other options to take. But I just put one patient back on TDXD after the ILD resolved in 3 weeks with a short burst of steroids at a lower dose. So this is something we often use in clinic, good strategy.
So let's finish out again with sort of more of a broad view of the management of metastatic triple-negative disease and how these findings from ESMO are affecting how you think this through. So just like the way we looked at ER-positive disease, we're breaking it down into either HER2 low or not, but now we also have PD-1 level to consider, and these patients, obviously, if they're PD-1 positive, are going to get immunotherapy. So again, Giuseppe, can you talk a little bit about, assuming you have sacituzumab, datopotamab, even sac-TMT available, how are you going to think about sequencing in these patients, whether they're HER2 low or HER2 negative?
So following the data of ASIANT-4, I believe the new standard of care should be an ADC plus immunotherapy if you are PD-L1 positive. So in my ideal world, I would see in the first line triple negative an anti-TROP2 ADC plus pembrolizumab or plus durvalumab. And then if progression to this, if not BRCA mutant, of course, a standard chemotherapy for me with platinum salts. If BRCA mutant, of course, a PARP inhibitor. So we have to be clear here. The new first-line treatment in triple-negative PD-L1 positive is sacituzumab govitecan plus pembro. In the PD-L1 negative is datopotamab or sacituzumab. And in the new guidelines of ASCO-ESMO, this will be the new treatment algorithm. In the second line, I would use carbogemcitabine, of course, and in BRCA mutant, eventually, of course, PARP inhibitor. And don't forget to consider a clinical trial, because in the second line, attrition rate is very high, so a clinical trial can be an excellent option for our patients.
So then we also, Priyanka, have to consider the patient who's PD-1 negative, both HER2 low and HER2 negative. Again, and I think maybe I should ask too, I know there's another trial looking at Dato plus IO. We don't have that yet, but I imagine that's going to come along at some point. So we may have that choice, but at this point we have SASI in the PD-1 patients. So what about PD-1 negative? Now we have data with two TROP2 ADCs. How are you going to think that through? HER2 low, again, TDXD is an option, and then HER2 zero.
So for triple negative, regardless of HER2 low or not, I think a TROP2 ADC is the first line option. The DB06, the first line trial with the TDXD was just for hormone positive patients. Between Dato and SASI, I think it again will depend on patient baseline characteristics, their wishes, availability, cost, what's on compendia, what's on our formulary at individual institutions, but it's nice to have options from the patient perspective.
So I'm just taking a breath and thinking about a general medical oncologist is just sorting out, like in the last 2 days, we went through CAR T therapy yesterday. The day before, we went through 1 hour just on small cell cancer of the lung. One of our abstracts at San Antonio, we asked the oncologist how familiar they are with the 12 phase 3 randomized trials you need to understand in order to decide second-line therapy of ER-positive metastatic disease, giving you a little bit of a hint of what these docs are trying to consume in their brains. And I just can't say enough about how much we admire these docs that try to keep up to date with this very exciting but rapidly changing landscape. Priyanka and Giuseppe, thank you so much for attending. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Priyanka. Thanks, Giuseppe.
Thank you.
Thank you for the invitation.